Dr. Allaf. I am a psychiatry resident working with Dr. Bryan and Dr. Terry. Today's presentation will be on childhood and early onset behavioral and psychological disorders. In this PowerPoint presentation, we will cover common neurodevelopmental conditions seen in both children and adolescents. This will include autism, ADHD, intellectual disability, and disruptive behavior disorders. We will also touch on their evaluation, treatment, and clinical considerations. These are some common learning objectives for this presentation. Overall, after this presentation, you will learn how to recognize diagnostic criteria for common child psychiatric disorders, understand how presentations differ by age group, identify evidence-based treatments, including medication and therapy, analyze the biological and environmental factors that contribute to disorders such as ADHD, autism, and conduct disorder, and then also evaluate treatment pros and cons, especially for pharmaceutical interventions. Child psychiatry is a subspecialty focusing on behavior, development, and the environment's impact on mental health. We will divide it into 3 stages. First, children, early school age, behavioral and developmental concerns dominate. In adolescence, mood and anxiety disorders become more prevalent. Finally, transitional age use, ages 18 to 26 years old. These will be adults with lingering or late onset pediatric style concerns, often benefiting from child-trained providers. Children often present with complex overlapping symptoms. Distinguishing between developmental appropriate behaviors and pathology is crucial. Risk factors like trauma or cultural variation further complicate their diagnosis. Always remember, children can assent, but they cannot legally consent. Legal guardianship and foster status may also impact treatment planning as well. Here we have some terminology for development. Let's start from the very beginning, from prenatal, which is considered conception to 8 weeks. Then the fetus, which is 8 weeks till birth. Then infant, which is birth to 1 year, which is primarily reflex driven. Then we have toddlers ages 1 to 3 years of age, which is primarily focused on language and toilet training. Then we have preschool, which is 3 to 5 years of age, where imaginative play is normal. In addition, we have some other developmental milestones, which includes school-age children, which is ages 5 to 12, during which time period they build complex language, dream vividly, and rely on family routines. We then have adolescents, ages 13 to 18 years old, during which they explore their identity, morality, and engage in risk-taking behaviors. Finally, we have transitional youth, ages 18 to 26 years old, which often need ongoing support due to early adversity or psychiatric conditions. In terms of development, there are several different ideas that discuss how development is impacted and influenced even in the early stages of life. For instance, Thomas and Chess demonstrated and described temperamental differences amongst newborns. This demonstrated that there were behavioral influences prior to birth. Also, prenatal and fetal damage usually has a more global impact than damage after birth. For instance, XY, or male, are more vulnerable to developmental damage than XX, which is true of both humans and also other animals. It is thought that the second X chromosome is actually protective. In addition, another idea is that maternal stress can have a large impact on development. This is from that increased maternal stress is more likely to produce children with increased anxiety, more hyperactivity, children that are more irritable, and also children with a lower birth weight as well. There are several prenatal risk factors. Again, these behavioral and cognitive traits can begin in utero. This is seen from, again, maternal stress, increasing future anxiety and hyperactivity. There is also the impact of substances, which have different varied effects. For instance, alcohol can cause fetal alcohol syndrome. Tobacco can cause prematurity and also increase the risk of SIDS. Cocaine has increased risk of ADHD and poor bonding. There are also several medications like lithium and valproate which are known to have teratogenic effects. Now we're going to discuss a child psychiatric evaluation. When evaluating a child, you have to use age-appropriate questions, and you also have to determine if developmental milestones are being met, while also evaluating attachment to their caregivers. And then finally, it is actually very crucial and important to get collateral information from both teachers and the parents. These individuals, the teachers and the parents, will know the child's functioning better than what the child can articulate. There are some very common childhood psychiatric disorders. These disorders include intellectual disability, autism spectrum disorder, ADHD, tic disorders such as Tourette's. There are also several mood, anxiety, trauma, and conduct-related disorders. Early diagnosis is very key for proper intervention. All of these disorders are categorized under neurodevelopmental disorders and the DSM-5. Severity of intellectual disability depends on different adaptive functioning. For instance, mild intellectual disability is when the individual has reached 6th grade academic level. Moderate intellectual disability is when the individual only reaches 2nd to 3rd grade level. Severe intellectual disability is when the individual has basic literacy and needs supervision. Finally, profound intellectual disability indicates that the individual has limited self-care and medical causes are very likely contributing to the intellectual disability that this patient has. IQ scores have been used, however, adaptive behavior is much more important for the diagnosis. In the past, there were terms that were used but are now outdated. These terms include the words idiot and moron, which were based on IQ scores. However, Rose's Law in 2009 replaced mental retardation with intellectual disability in legislation for the United States. It is very important to use respectful, personal language first, and know that ICD-10 as well as ICD-11 and DSM may use slightly different terms. In terms of intellectual disability, it is also important to note there are several genetic causes as well. For instance, there is Down syndrome or trisomy 21, Fragile X, which is due to FMR1 repeats, Prader-Willi, Rett syndrome, PKU. Finally, it is important to note that some of these genetic causes are either X-linked, autosomal recessive, or autosomal dominant, and that many of these are associated with specific physical findings as well. There is also acquired causes of intellectual disability, which are during the prenatal period. For instance, these are infections from rubella, CMV, toxo, HIV. In addition, as previously mentioned, there is also substances such as fetal alcohol syndrome and also prenatal drug exposure, including several different medications like previously discussed, including valproate and lithium. Acquired causes of intellectual disability also include complications during pregnancy, which would include hypoxia, preeclampsia, amongst many others. Also, in terms of acquired causes of intellectual disability, there is also ones during the postnatal period. or post-birth. These causes include brain infections such as meningitis, head trauma, lead poisoning, or chronic illness or treatment including chemotherapy. Now, in terms of intellectual disability, there is the DSM-5, which has set certain parameters or criteria. The diagnosis requires deficits in intellectual function, including reasoning, problem solving, and academic learning, deficits in adaptive functioning, including independence and social skills, and then also including, as a criteria, onset during the developmental period. All three of these criteria must be met for diagnosis of intellectual disability according to the DSM-5 criteria. In addition to the DSM-5, we're going to further discuss evaluation of intellectual disability, as well as begin our discussion on treatment of intellectual disability. So continuing forward with evaluation of intellectual disability from the criteria of the DSM-5, the evaluation of the patient will include neuroimaging, genetic testing, physical and neurological examinations, hearing and speech tests, IQ testing, adaptive functioning testing as well. Hearing and speech evaluations I want to particularly note because these are often tested on boards. This is done by the pediatrician and also at school. When identified early, this can mitigate some effects of intellectual disability. Moving forward to treatment, there are different types of treatment modalities that exist. First of all, there is primary prevention, in which you're trying to treat the underlying disorder. In addition, you are also trying to prevent or reduce conditions that may lead to intellectual disability by educating the general population. On the other hand, we have also secondary and tertiary prevention, which is trying to minimize the consequences or consequent disabilities of the patient. Continuing on with treatment of intellectual disability, we also have educational interventions. For example, this will include the 504 plan, which is getting general extra help for disabled children. Then there's also individualized education plans, otherwise known as IEPs, which is more of a structured approach for the individual student or patient based on their psychological testing. As a side note, there is a diagnosis called gross developmental delay, which is reserved for individuals under the age of 5 years old, when the clinical severity level cannot be readily assessed during early childhood. It is also important to note for neurodevelopmental disorders that there are very different types of communication disorders that are prevalent in the DSM-5. This would include speech disorders, language disorders, hearing disorders, and also central auditory processing disorders. The DSM-5 criteria for these conditions are not included in this PowerPoint as they are likely low yield for COMLEX or USMLE. However, the names of the diagnoses are more likely to show up. The treatment for these different conditions is going to be speech therapy. Now we're going to begin our introduction for autism spectrum disorder, otherwise known as ASD. ASD is characterized by persistent deficits in social communication and also restricted repetitive behaviors. Again, it's important to remember that autism spectrum disorder is truly a spectrum, meaning presentations can actually vary widely. Some kids are nonverbal, while others have near normal speech but struggle with social interactions. It is also a myth that autism is caused by vaccines. However, this is significantly not true. The main idea and principle behind this is that autism is actually more diagnosed nowadays compared to previous generations. This is due to two reasons: better screening and more inclusive criteria. It is important to remember that the main goal is to help people. By expanding the inclusion criteria, more services are available to people who would benefit from such services. In terms of autism spectrum disorder, there is the DSM-5 criteria, which is available in the notes in your PowerPoint. There is common signs and also comorbid conditions. Core features of autism spectrum disorder include poor eye contact, lack of interest in peers, repetitive behaviors such as lining up toys, the patient's insistence on sameness, and also sensitivity to certain sensory stimuli. Again, just like other neurodevelopmental disorders, early intervention for autism spectrum disorder is crucial for better long-term outcomes. In terms of autism spectrum disorder, there has been risk factors that have been noted. For instance, there is a genetic component for which siblings of autism spectrum disorder have higher risk. Environmental, which is advanced paternal age, low birth weight, and valproate exposure increases risk as well. And again, going back to a previous slide, vaccines do not cause autism. And on this slide, we will also discuss treatment. Treatment for autism spectrum disorder could be divided into both pharmacological management and non-pharmacological approach. While there's no cure for autism spectrum disorder in terms of medication, medications can be used in conjunction with appropriate behavioral and environmental interventions to improve symptoms. Such medications that could be used is stimulant medications for inattention, then alpha-2 adrenergic agonists such as clonidine or guanfacine could be used. In addition, atypical antipsychotics such as Risperdal or risperidone or Abilify could also be used. In addition, anticonvulsant mood stabilizers such as valproic acid are another type of medications that could be used for treatment of autism spectrum disorder. It has also been noted that SSRIs may also be helpful for symptoms of anxiety, depression, or repetitive behaviors in those with autism spectrum disorder. It is very important to note that with all medications, you have to consider the adverse side effects that are always a risk for the patient. Continuing on with the treatment of autism spectrum disorder, there is also non-pharmacological management, which is a very important and crucial part of the overall treatment plan. There is the applied behavior analysis, or ABA, which is a popular treatment that encourages positive behaviors and discourages negative behaviors. This can be divided into further subtypes, which are shown on the slide, and also further detailed in your notes. Continuing on for our third slide of autism spectrum disorder treatment, there are other modalities of treatment that could be used. This includes DIR, which stands for Developmental, Individual Differences, and Relationships. This treatment modality focuses on emotional and relational development. In addition, there is speech therapy, which helps improve verbal communication skills, occupational therapy, picture exchange communication system, treatment and education of autistic and related communication handicapped children, and also sensory integration therapy. These are all, again, different modalities that can be used to treat autism spectrum disorder. It is very important to note that a multidisciplinary approach and care of the patient is very essential and crucial. We will be continuing on with the next neurodevelopmental disorder, which is ADHD. ADHD has multiple different subtypes, and these subtypes include inattentive, hyperactive/impulsive, and also combined types as well. It is very, very important to note that for ADHD, the symptoms have to be consistent for at least 6 months, and that the symptoms must be present prior to the age of 12. This is very important to note, not only for your exams here, but for also COMLEX and USMLE. Also similar to autism spectrum disorder, teacher input and rating scales will be very helpful to make the diagnosis of ADHD. The criteria for ADHD is going to be incorporated on the next slide for your overall reference, but it is generally self-explanatory. But again, the criteria is that is really crucial that symptoms need to be present before the age of 12. And how do you determine when to treat or when do you treat a patient with ADHD? That decision is truly based on when it is affecting the child's ability to learn. Again, in terms of ADHD symptoms and criteria, this would include inattention, such as careless mistakes and disorganization. There is also hyperactivity, in which the child will fidget and leave the seat constantly. There is also impulsivity, in which the patient will blurt answers and cannot wait their own turn. And always consider, in terms of ADHD, the developmental context of the patient as well. I just want to note one more time that the DSM-5 criteria for ADHD is available in the notes section. So how do you treat ADHD? The first-line treatment for ADHD is a combination of medication and CBT targeting executive dysfunction. There has been very strong evidence that suggests a combination of both stimulant medication and CBT together is greater than either one of them alone in terms of their impact on the patient. Again, first-line treatment for school-age children and adolescents is stimulant medication. These stimulant medications work by increasing both dopamine and norepinephrine to make these neurotransmitters more available. This improves transmission and communication in different parts of the brain. It also helps reduce hyperactive and impulsive behaviors. There's also non-stimulant medications such as atomoxetine and bupropion, as well as alpha-2 agonists such as guanfacine and clonidine. As with any medication, there are potential side effects, and more commonly in terms of the stimulants, there is insomnia, irritability, diminished appetite, weight loss, and headaches. On the other hand, non-stimulant medications can cause similar adverse side effects, but with more gastrointestinal and genitourinary symptoms such as nausea, constipation, decreased libido, and urinary hesitancy. For those who need to avoid stimulants, atomoxetine, which is a non-stimulant, is very appropriate. As previously mentioned, there is also the option of alpha-2 agonists, such as guanfacine and clonidine. The adverse effects of these medications include central nervous system depression, bradycardia, hypotension, respiratory depression, and miosis, or shrinking of the pupil. Continuing on with treatment of ADHD, there is important to note the pros and cons of pharmacotherapy. Untreated ADHD can lead to extremely poor outcomes that accompany ADHD symptoms. In addition, many people with untreated ADHD complete less schooling, hold lower paying occupation, and suffer from poor self-esteem and harmful relationships. This is because ADHD affects all aspects of life, from childhood into adulthood, causing both deficits in academic and social settings. As a result, treatment should begin immediately after diagnosis, which can yield significant long-term benefits. In addition, it's also important to note that regular follow-up is crucial to monitor both the effectiveness and side effects of the medications that are used to treat that respective patient. For example, it would be very important, again, to note the appetite suppression or sleep issues which may be happening with the patient. Continuing on with neurodevelopmental disorders, in addition to ADHD and autism spectrum disorder, there's other disorders that include learning disabilities, communication disorders, and specific learning disorders as well. The learning disorder criteria is low yield. However, the main points for these learning disorders is that you need at least 6 months of difficulty with reading, writing, and/or mathematics. This also needs to start during school age years at the latest. The treatment for specific learning disorders typically is scholastic in nature, which is an individualized education program as an IEP, as previously mentioned. Continuing on with different types of disorders, there are motor disorders. Motor disorders are several in the DSM. However, there are more particularly high-yield motor disorders for your exam. These include tic disorders and Tourette disorder. This is very important to be mindful of because stimulants, cocaine, and other dopamine agonists can initiate or imitate tics, and because dopamine blockade can treat these tics, they are thought to be mainly a dopamine process and the caudate imputamen, causing disinhibition. Also, just a note, a tic is a sudden, rapid, recurrent, non-rhythmic motor movement or vocalization. This is why a multidisciplinary approach is very essential. You want to make sure that you coordinate care across specialties, including psychiatry, pediatrics, neurology, and educational services. Ongoing monitoring ensures that interventions remain appropriate as the child matures. Continuing on with motor disorders, this is the criteria for both common motor and vocal tics. First is Tourette's disorder. Tourette's disorder includes both multiple motor and one or more vocal tics that have been present at the same time during the illness, although not necessarily concurrently. There is also persistent or chronic motor or vocal tic disorder. This is single or multiple motor or vocal tics that have been present during the illness, but not both motor and vocal. This is really important because you want to rule out Tourette's disorder. This is why it is very crucial to specify for every patient that you encounter if it is motor tics only or vocal tics only or both. There is also provisional tic disorder, which is single or multiple motor and or vocal tics. You need to rule out Tourette's disorder or persistent or chronic motor or vocal tic disorder when considering this diagnosis. Please refer to the DSM-5 criteria, which is available in your notes. In this slide, we're going to discuss comorbidities that are associated with these motor disorders or tic disorders. It is very important to note that ADHD, tic disorders, and OCD are one of the triads in psychiatry. If a patient has 2 out of the 3 disorders, be wary of the third potential diagnosis. For example, if a patient has Tourette syndrome, be hypervigilant for OCD, ADHD, and depression. There's also another particular diagnosis called PANDAS, or pediatric autoimmune neuropsychiatric disorders, associated with strep infections, which is a diagnosis for a subset of children with rapid onset OCD or tic disorders. It is currently a very controversial diagnosis because there is no clear causation. However, there seems to be an ample correlation. Just wanted to note this as it may show up on your board exams. In terms of treatment for these tic disorders, one treatment is habit reversal therapy, which is a form of CBT. Another form of CBT is exposure and response prevention. You could also use medications such as antipsychotic medications, including haldol-paridol. However, using any medication, you need to consider the risk versus the benefit. For example, does that patient truly need to be treated with medication? There are other medications, including clonidine, guanfacine, and atomoxetine, which may be helpful. However, it is important to note if they are on a stimulant already, you should stop it. Now we're going to transition to depressive disorders in children. Depression in children has the same criteria as adults, except depressed mood is replaced with irritable mood. The treatment is also very similar. However, it is important to note that dosing is started at lower titration and is titrated slower also in children. Therapy is still indicated and recommended. It is also important to note that for children less than 7 years old, they do not typically understand the finality of death. which is important for considering the aspect of suicide or suicide ideation. There's also psychiatric disorders that are prevalent in adolescents. Youth have the same diagnostic criteria and treatment as adults as well. It's important to distinguish normal behavior from an underlying psychosis. Auditory hallucinations are the most common hallucination in psychosis. Also, there are many psychotic symptoms that are less likely attributable to depression, anxiety, or traumatic stress disorders compared to an underlying psychosis. If an adolescent presents with symptoms consistent with an underlying psychiatric disorder or psychotic disorder, it is imperative to thoroughly evaluate any particular underlying cause, including labs, imaging, and also obtaining collateral information from other individuals such as parents and teachers. This is especially important for first break psychosis. There's also children with early onset bipolar disorder. However, this is rare. Many of the symptoms are found in adolescence. However, bipolar 1 is often overdiagnosed. This led the DSM-5 to actually include disruptive mood dysregulation disorder. This is characterized by severe, developmentally inappropriate, and recurrent temper outbursts at least 3 times per week, along with a persistently irritable or angry mood between these temper outbursts. The treatment for this disorder is therapy. You can also use a second-generation antipsychotic or mood stabilizer if truly necessary. There's also disruptive mood behaviors. These are mostly unknown in terms of their cause. However, the disorders are thought to spring from different factors working together. For example, heredity and environment. These include defiance, aggression, and violation of rules. These disorders often coexist with ADHD and or mood disorders and require comprehensive treatment. Again, going back to what was previously mentioned, the causes of these disruptive behavior disorders are mostly unknown and thought to spring from different factors working together. As previously mentioned on the other slide, in terms of hereditary and environment, there's also potentially physical and psychological causes. Again, treatment is behavior focused. You want to help develop more adaptive behaviors to cope with their stressors and decrease symptom severity. There's also impulse control disorders. Impulse control disorders include intermittent explosive disorder, kleptomania, and pyromania. These involve failure to resist aggressive or destructive impulses and are treated primarily with psychotherapy. To go through more of the impulse control disorders, the first is kleptomania, which is an uncontrollable repetitive impulse to steal. Even though the child is aware that this behavior is wrong, they still continue to do it. Other forms of impulse control disorders that are often present in children or adolescents include pyromania, which is a deliberate and purposeful act of setting things on fire in order to receive instant gratification or as an attempt to resolve tension. There's also compulsive sexual behavior, which is excessive or uncontrollable thoughts or behaviors revolving around sexual activities. There's also intermittent explosive disorder, which involves recurrent behavioral outbursts that represents a person's inability to control aggressive impulses. The next is oppositional defiant disorder. ODD is characterized by a pattern of angry, defiant behavior towards authority figure. It typically starts by the age of 8 and can strain both family and school relationships. In terms of ODD, think of the terrible twos with the temper tantrums. But now imagine it with a school-age child of 5 to 12 years old, or even older with similar outbursts. Individuals with ODD are likely to be uncooperative, argue, refuse to follow rules, deliberately annoy others, blame others for their mistakes, and behave in angry, resentful, spiteful, or vindictive ways. The ODD criteria, as reflected by the DSM-5, is that these presentation or symptoms have to be lasting at least 6 months, as evidenced by at least 4 symptoms from any of the following categories mentioned on the slide. Overall, the disturbance in behavior is associated with distress in the individual or others in his or her immediate social context, such as family, peer group, and or work colleagues. It will also impact negatively on their social, educational, occupational, or other important areas of their life and functioning. In terms of the behavior disorders, such as oppositional defiant disorder versus conduct disorder, you want to make sure that you distinguish between the two of them, as this will often appear on your exam. This will also help in terms of overall prognosis and treatment planning. ODD in particular has a more favorable prognosis if addressed early with behavioral intervention. The differences between ODD and conduct disorder are noted on the slide. Also, in terms of behavior disorders, we also wanted to be able to differentiate 2 other diagnoses, which is disruptive mood dysregulation disorder, or DMDD, versus bipolar disorder, again in children and adolescents. This slide is a very great example of being able to differentiate between the both of them. However, very briefly to go over it, DMDD does not necessarily involve hypomania or mania. There is also a persistently low mood lasting for at least 3 months in a 12-month period. Also, irritability is constantly experienced. Versus bipolar disorder, it does involve a manic or hypomanic episode. The low mood may last for several days or weeks, and there are also frequent mood swings. Make sure to review this slide in order to best differentiate between these 2 diagnoses. The next couple of slides we will discuss conduct disorder. Conduct disorder is a repetitive and persistent pattern of behavior in which the basic rights of others or major age-appropriate societal norms or rules are violated. This is manifested in the presence of at least 3 of the following 15 criteria for the past 12 months from any of the categories below, with at least 1 criteria present in the last 6 months. Please review the slide for all the criteria mentioned. Again, the criteria includes that the disturbance in behavior must cause clinically significant impairment in social, academic, or occupational functioning. It is also important to note that if the individual is 18 years old or older, criteria are not met for antisocial personality disorder, which is very similar in terms of presentation. Again, conduct disorder in terms of criteria, it is an aggressive pattern of behavior that affects others, often with less empathy. The symptoms include varying patterns, including aggression to people and animals, destruction of property, theft, serious violations of rules, in addition to parental neglect and excessive punishment can contribute to this development. Conduct disorder is often diagnosed under the age of 18. If the person is over 18 years old, it would then be considered antisocial personality disorder. However, it is important to note that conduct disorder does not typically become antisocial personality disorder. So what is the treatment for conduct disorder? Medication and treatment includes antipsychotics to help reduce aggression, but again, with the use of antipsychotics, you always want to weigh the risks versus the benefits, especially with children and adolescents. Family therapy is often the best course of treatment for conduct disorder. Typically, patients with conduct disorder are not distressed by their behavior. However, there is almost always major family issues and dysfunctions that contribute to or limit their treatment of the patient's problem. Therefore, family therapy is a treatment of choice. In addition to behavior management, effective therapy requires parental consistency and reduction of marital or intergenerational conflict. For conduct disorder, there are child rearing practices that are related to this diagnosis, Monitoring of children's activities and whereabouts by adult caregivers is critical. Also, compliance with evening curfew is essential. For working parents, telephoning to check on the child or having another responsible adult ensure that the child is in an appropriate setting during non-school hours is also very important. Monitoring becomes particularly important during early adolescence when the child's peer group influences their behavior increasingly so. Vulnerable youths are susceptible to peer influences such as smoking, sexual risk-taking, and alcohol or other substance use. Organized, supervised activities such as sports, scouts, arts, or recreational programs are often help protect teenagers from negative peer influences. Continuing on with child-rearing practices related to conduct disorder, parents should always communicate clear, direct, and specific requests. For example, I would like you to set the table for dinner now. Also, importantly to note, requests should not be negative or qualified. For example, do not waste all your life in front of the television. Maybe you could be useful and help with dinner. If the requested activity is not initiated within 5 seconds, a verbal reminder should follow. When the request is made for a third time, a clear, reasonable consequence should be added. For example, if you have not finished setting the table in 15 minutes, you will lose 1/2 hour of free time with your friends tonight. The chosen consequences should be restrictions that the parent can realistically implement rather than those that are vague and unenforceable. Again, continuing with child rearing practices related to conduct disorder, while adverse consequences, like those mentioned in the previous slide, may be necessary at times, parent-child interactions should also include rewards. Positive enforcement for desirable behavior will reduce the reliance on punishment. Importantly, rewards should be concrete, specific, and always provide promptly when the child meets the criteria. For example, if you set the table by 6 p.m. each night this week, you can choose a video to rent on Saturday night. In addition, parents of children with conduct disorder typically rely on inconsistent coercion rather than enforcement in a family climate high in negative exchanges. Because television, movies, and video games are reinforcing to many children and adolescents, they are often used as rewards. However, children who are at risk for conduct disorder may be more likely to exhibit aggressive behavior in response to viewing violence. Therefore, access to these reinforcers should occur with parental supervision. As we conclude our presentation today, we want to make sure that we review the medication use in pediatric psychiatry. First, we'll review the medications that are used in ADHD. One class of medications that could be used is amphetamine salts, which block the reuptake of dopamine and norepinephrine, while also help stimulating the release of dopamine. Another treatment modality is methylphenidate, which blocks the reuptake of dopamine and norepinephrine. On the other hand, you can use a non-stimulant, which is atomoxetine, which acts to be a selective norepinephrine reuptake inhibitor. If you don't want to use a stimulant or non-stimulant, you can also use guanfacine or clonidine as other options. Both of these medications are alpha-2 agonists that are used again for the treatment of ADHD. Moving forward to depression and anxiety, in the pediatric population, you can use SSRIs, or selective serotonin reuptake inhibitors. If an SSRI does not work, you can also use bupropion, which is a norepinephrine and dopamine reuptake inhibitor. Moving forward to the disruptive, impulse control, and conduct disorders, you can use antipsychotics. Antipsychotics will help control impulse issues that are seen in these disorders. To note, antipsychotics can also help the impulse control issues seen in autism as well. On the other hand, you can also use lithium and valproate for mood stabilization and treatment of aggression and conduct disorder. If a pediatric patient presents with psychosis, you can use antipsychotics. The antipsychotics will help control mood, psychosis, and aggression within these patients. For other disorders, such as OCD, you can use desmopressin, which is used to treat osteoenuresis. This is the conclusion of our presentation. Thank you for your attention throughout this entire presentation today. Child psychiatry is truly a dynamic field that requires collaboration, compassion, and continuous learning. Remember that early recognition, family engagement, and integrated care are the keys to supporting mental health in children and adolescents.